Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today's video is completely about cholinergic pharmacology. It's the dental pharmacology's foundation, Autonomic Nervous System Part 1. So we need to understand that our bodies have two systems that balance each other. We have the parasympathetic nervous system balanced with sympathetic nervous system. Parasympathetic is referred to as cholinergic pharmacology, and sympathetic nervous system as adrenergic. We need to maintain a balance between these two, and therefore there are two lectures of autonomic nervous system. This one is about this section here. So remember, these exams such as AFK, INBDE, NEET for example, and especially when we study BDS or DDS. These exams, these courses are based on conceptual knowledge. Therefore, the Tooth Factory brings to you the foundation concepts of pharmacology and many more subjects. So please take out your pens and papers, and here we go. Before we begin, we will discuss a background of nervous system, and then we'll dive into autonomic nervous system, where we'll discuss the neurotransmitters and their receptors. Then we'll take a look at what parasympathetic nervous system takes care of, and sympathetic, and then dive deeper into the cholinergic pharmacology, which is just another way of saying parasympathetic nervous system. We'll look at the actual drugs involved, agonists and antagonists both, and in the next lecture, we'll discuss about the adrenergic pharmacology. There's some important concepts at the end, and then references. So this is a comprehensive lecture, guys, so it may be a little dry, but we'll try and make it as interesting as possible. For example, this picture. Everything in red depicts the sympathetic actions, where everything in blue depicts parasympathetic. So for the sake of this lecture, let's take a look at an example of the blue. Say, the heart. It is a decreased rate of heart and decreased contractility of heart, basically low blood pressure and low heart rate. Now this doesn't mean bradycardia or hypotension. All this means is that in order to balance the functions of the body, the parasympathetic nervous system, the cholinergic physiology, will allow a reduction in blood pressure and a reduction in heart rate to a heightened response, basically whenever your body is in hypertension due to the sympathetic nervous system's actions. That's when parasympathetic nervous system kicks in to reduce the blood pressure, basically to calm you down. That's the balance that we speak of. Therefore, another example is lacrimal glands. Whenever you're completely dry and your eyes are itching, you need to understand that we need to calm down. And that's why parasympathetic nervous system kicks in and stimulates tears. That's just another way of saying balancing and calming the effects. Speaking of which, the nervous system. We know there are two sections, central nervous system and peripheral nervous system. Central nervous system consists of the brain and spinal cord. Peripheral consists of somatic nervous system and autonomic. Autonomic means involuntary, something that the body, the brain, and the organs and the nervous system controls by itself, where somatic is voluntary, such as making a fist, or muscular movements, such as skeletal muscles, right? Skeletal muscle movements, also known as striated muscle movements. So we're not going to talk much about this, as we're going to discuss about the autonomic nervous system. The sympathetic is the next lecture, and this one is parasympathetic, which is this lecture here with cholinergic pharmacology. So what is the autonomic nervous system? It consists of both parasympathetic, sympathetic nervous system. We've just talked in depth about that. And they both hold involuntary functions. They both are opposite in action, as we've understood, and the balance is completely essential to maintain equilibrium of the body. In parasympathetic nervous system, the cholinergic or parasympathomimetic pharmacology is balanced by anticholinergic. So just within parasympathetic nervous system, we have two types of drugs and pharmacology that is introduced. One is cholinergic, which is helping the parasympathetic nervous system. And then there is anticholinergic, which suppresses the parasympathetic nervous system. So it is important to understand how they do that. To do so, let's talk about neurotransmitters. So I'm going to avoid talking about this section here, as we will discuss this in the next lecture. Let's talk about this side here, cholinergic. We know it's rest and digest. Parasympathetic allows you to be calmed, so calming effect, rest and digest. And neurotransmitter, basically the messengers that allow this to be connected to throughout the body, is known as acetylcholine, for short ACH. This is the one and only neurotransmitter that cholinergic pharmacology uses. The receptors that they communicate at, basically the docks where these land and act, are called muscarinic and nicotinic. So here's a picture of a synapse. A synapse has a presynaptic vesicle that makes this area a synapse, and then a postsynaptic receptor, where these little neurotransmitters will attach and affect at the target tissues on the other side of the synapse. There are certain enzymes that act in the synapse to imbalance or balance the actions of neurotransmitters. And again, this whole thing begins at the central nervous system. The brain and the spinal cord will dictate where everything will go. Moving on, this is a picture from the textbook, our reference for NDEB and INBDE, where autonomic nervous system here has a pathway that we can discuss in detail about parasympathetic in this video, and we'll touch up a little on sympathetic nervous system as well. So parasympathetic, we know that from the CNS, acetylcholine is released, right? The neurotransmitter for parasympathetic. It will attach at a central site called as the ganglion. Now we've introduced a new word. What's a ganglion? A ganglion is basically a relay center. So imagine this, the CNS releases neurotransmitter, touches the ganglion, and then it gets relayed out to muscarinic or nicotinic receptors. Right? Now the ganglion acts as a refueling station. See, your flight took off from here, had a layover at another airport where it refueled, and then went to the actual target. Sometimes you need to change planes at the connecting airports, right? Keep that thought in mind. For example, in sympathetic nervous system, acetylcholine is where it begins, reaches the ganglion, and then the blue part, norepinephrine, is the flight you have to take to get to your destination. While in parasympathetic, you take acetylcholine, you go to the ganglion, you stay on the same flight, and then reach your destination. Now, I know it sounds a little confusing, but we'll clarify it in just a bit. Here's another view of it that allows us to understand all of these compartments together. We know that peripheral autonomic nervous system is consisting of either parasympathetic or sympathetic. What we need to understand is, first we need to get to the connecting airport before we can reach the destination. Okay, let's keep that in mind for now. I'm going to take this slow so everyone gets the concept. The connecting airport is always the same. It's known as ganglion, and ganglions have receptors on them. Those receptors are always nicotinic receptors. By always, I mean whether it is parasympathetic or sympathetic, it's always going to be nicotinic. Okay? Now keep this in mind that nicotinic receptors can only accept acetylcholine as a neurotransmitter. That's it. It's a cholinergic receptor. So it can only accept a cholinergic neurotransmitter, right? So if all ganglions are nicotinic, that means all of these preganglionic neurotransmitters will always be acetylcholine, whether it is parasympathetic or sympathetic. Okay, so let's go back to the picture here. we need to understand the concept that all preganglionic neurons, the ganglionic transmitters, will always be acetylcholine, no matter what system in the body you're looking at. And all the ganglions here, this ganglion here, will always be nicotinic. So let me show you this with much ease. This is ganglion, and they're all nicotinic receptors, right? Whether it is sympathetic or parasympathetic, doesn't matter. All ganglions will be nicotinic, which means if nicotinic receptors are existing at the ganglions, and the rule is that they can only accept cholinergic neurotransmitters, then all preganglionic neurons, the ganglionic transmitters, will always be acetylcholine, despite which system it is. Okay, so we're halfway there, guys. We have reached the ganglion. Now, postganglionic neurotransmitters are different. They can be either acetylcholine or norepinephrine, depending on the destination, right? So after the connecting flights are taken, you either get to stay on the same flight, or you got to change your flight to get to your target destination. How do we determine that? That is determined on whether it is parasympathetic or sympathetic nervous system. If it's parasympathetic, it will always be acetylcholine, so you don't have to change the flight. You can always stay on the same, let it refuel at the ganglion, and move towards your target tissue. But if it's a sympathetic nervous system here, then acetylcholine will touch the ganglion, and after the ganglion, the airport, we need to change our connecting flights to norepinephrine, where norepinephrine will go to the target tissues. So let's take a look at this diagram again. That sympathetic nervous system will have norepinephrine as its postganglionic neuron, while parasympathetic will always have acetylcholine. We don't have to change the flight. It remains the same. While in sympathetic, we have to change the flights. Now, keep this in mind. At the destination, because your neurotransmitter changed, your receptors at the target will also change. And sympathetic nervous system's receptors are called adrenergic receptors. Again, this is the second lecture, so we won't worry much about that now. But parasympathetic nervous systems are muscarinic receptors. So the target tissue will have either muscarinic receptors for cholinergic or adrenergic receptors such as alpha and beta for sympathetic nervous system. Okay, moving on. The parasympathetic nervous system. So now everything is clear, guys, right? We have parasympathetic nervous system. We can also call it cholinergic, where ACH is released preganglion, touches the ganglionic receptor, which is nicotinic, always, remember that, always. And we refuel our plane and get on the same flight as acetylcholine, referred to as postganglionic neuron. And that neurotransmitter will go to a muscarinic receptor because muscarinic is cholinergic receptor. Perfect? Those could be at either smooth muscles in the body, at various glands, or in the heart at the target tissue. So let's talk about the overview. The rest and digest, cholinergic pharmacology, right? This is the function. This is another name for parasympathetic nervous system. It provides the calming effect when agonists are used. We know what the agonist and antagonist are from our general pharmacology videos previously, so please do check those out as well. The neurotransmitters of the parasympathetic nervous system are acetylcholine only. The receptors of the parasympathetic nervous system are nicotinic, especially at the ganglion, and muscarinic receptors at the target. And the function is to conserve bodily functions of involuntary control in the body. So I hope all of these nervous system questions are clear for parasympathetic at least. Okay, let's dive into the pharmacology. By pharmacology, we refer to them as drugs, the medications, specifically agonists. So we know that cholinergic means parasympathetic, right? But when they support, when these drugs support the parasympathetic nervous system, we call them mimetic. They mimic it. Artificial drugs, synthetic drugs, semi-synthetic drugs that mimic the parasympathetic nervous system are known as cholinergic drugs. And they could be direct acting or indirect acting. Direct acting cholinergic drugs will act on the postsynaptic target receptors. Postsynaptic target receptors. It will enhance this bond right here. Right? So remember, just as a little recap, these neurotransmitters are ACH, acetylcholine, and these receptors are muscarinic because this is cholinergic. Indirect acting cholinergic drugs will either release more ACH, so from here, from the vesicles, it will release more ACH, or it will inhibit the synaptic enzyme known as cholinesterase. Here's a new term now, cholinesterase. This is what we're referring to. Any enzyme that ends with the letters A's is meant to break down. Okay, let's keep that rule in mind. This is known as breakdown. So, choline esterase, which means this enzyme will affect these neurotransmitters and break them down. Once they're broken down, they're useless, and they go back into this vesicle here to get rejuvenated and release, which means in the presence of cholinesterase, the levels of ACH drops. Therefore, we need to inhibit that enzyme. We need to kill that enzyme so that the levels of ACH remain stable. Therefore, indirect acting cholinergic drugs will inhibit the cholinesterase. Okay, now let's take a look at this diagram with a refreshed mind of the concept. Parasympathetic nervous system, ACH is the preganglionic, touches the nicotinic, which is the ganglion receptor, still the same plane, acetylcholine, reaching the muscarinic receptors. Clear enough? But think of it this way. When acetylcholine is formed and released, and when drugs are taken that make acetylcholine go up, the body doesn't know where to act at it. Therefore, everywhere that we see acetylcholine will go up. So, of course, parasympathetic nervous system is entirely acetylcholine. So, major function of acetylcholine will be on parasympathetic nervous system. However, in sympathetic nervous systems, preganglionic sector, there is also acetylcholine. In the somatic, which is the voluntary muscle movements, acetylcholine also acts. So somatic nervous system is also affected. Not as much as parasympathetic, but it is affected. Okay, we've talked a lot about acetylcholine, but what is it? Where does it come from? How is it released? Well, let's take a look at that. This is a preganglionic or presynaptic neuron, in other words, where choline comes into play with sodium pumps from outside the neuron. So choline comes in, and another molecule known as acetyl-CoA gets mixed to form acetylcholine. Okay, so the first is a synthesis of acetylcholine. Choline acetyltransferase will catalyze the synthesis of acetylcholine from choline to acetyl-CoA. Fair enough? These two molecules join. Then, in order to be protected from being broken down, a vesicle is created. Therefore, acetylcholine will enter these vesicles. It protects it from degradation. Once calcium, or energy, in other words, is introduced, there is a release of neurotransmitters. But there is something that blocks this release right here, and that is known as botulinum toxins. In other words, Botox. So let me put this into a practical perspective, guys. We've all heard of Botox surgery, right? Or Botox treatment. What is Botox? Botox is a toxin from a bacteria known as botulinum. Its job is to block ACH actions by blocking the release. This is the function of Botox. Now, how does Botox help in cosmetics? Well, remember when we said that in somatic systems, acetylcholine is used for muscle movements? Well, now let's link it back here. When Botox stops acetylcholine, then how will muscle move? It can't move. Therefore, all the muscles become stiff. That is why we can get rid of our wrinkles, our muscles are all stiff and they look very firm because of Botox. Because ACH is no longer reaching the target. It is not being released. And that's why Botox is used in cosmetics. Just as a perspective on what ACH does and what stops it. And then we're moving on to when ACH is released into the synapse, what happens to it as a neurotransmitter. So it can either bind to the postsynaptic receptor, and again, just as a recap, because we love recapping, it's going to be called as muscarinic receptors at the target because it's a cholinergic receptor. So it can either bind to it and give an intracellular response, or it can break down. It can break down by the enzyme known as cholinesterase. Remember that from the previous slide? Well, then acetylcholine will break into acetate and choline. And remember what happens to choline? It uses the sodium pumps to get back in with acetyl-CoA in order to form acetylcholine. So here's the life cycle of cholinergic pharmacology. I hope I'm not boring you guys. I know this is a dry topic, but we're trying to use stories to get your attention because these are important topics. If this concept is clear, then all of these pharmacological activities will be clear. Okay, guys. So when we're talking about agonists, we mean something that enhances the parasympathetic nervous system's actions. So where? What are these target tissues? What is this area? Or what is this area? Well, they could be cardiovascular systems, respiratory systems, GI tract, salivary lacrimal glands, or eyes and vision function. So let's take a look at what cholinergic pharmacology or what ACH does to these target organs. At the heart, the cardiovascular system, it will work to decrease the blood pressure, heart rate, cardiac output, chronotropic and ionotropic forces, leading to bradycardia and hypotension effects. So, it calms the heart. Remember, rest and digest. Remember that here, I'm going to write this right here. Rest and digest. Remember these words here. So it calms the heart down. In respiratory system, it increases smooth muscle activity, motility, and the secretions at the respiratory tract, causing bronchoconstriction. Now you ask, why does it increase the effect? Shouldn't it calm it down? Well, the way to remember this is when there is a better activity of the respiratory muscles, a better secretion of the respiratory muscles, those activities help us breathe better. And breathing leads to calming. Just a way for us to remember in a story form. But remember this, when there is a lot of muscle activity in the respiratory tract, it will cause bronchoconstriction, too much of activity, right? In GI system, it will increase the smooth muscle activity. Remember, ACH will help move the muscles, the smooth muscles. Well, same thing in the GI tract. Peristalsis is better, intestinal motility is better, and that's where digest comes into play. Salivary and lacrimal glands. It increases the secretions of the glands, such as salivary and lacrimal functions. What does that tell us? That it cleans better. What stresses us out the most? When we have a dry mouth or a dry eye, it's very itchy. Therefore, ACH will release more tears, saliva, to enhance the self-cleaning. So remember that. That's why it increases that. And I know it's very vague, but for us to remember the cholinergic functions, these stories are created. Eyes and vision, it increases the constriction of pupils, causing miosis, because then it helps accommodate near vision. It decreases the intraocular pressure. Now this statement is very important because intraocular pressure, IOP, will lead to glaucoma. Okay, very important term, guys. Keep your focuses here. When there is an increase in the intraocular pressure, which means in the eye, if all of this pressure increases inside the eye, the fluid pressure, right? Aqueous humor, vitreous humor, when they go up, you get glaucoma. Cholinergic drugs are supposed to calm you down, right? Well, they will decrease this intraocular pressure and directly treating glaucoma. So it calms you down. It will also increase the constriction of the pupils, known as miosis, and helps accommodate near vision. It helps us focus, basically, to what's close to us. Very calming. We don't need to know what's going on around us. We just need to know what's in front of us. Remember that. Cholinergic will calm you down, it will give you rest, and cause miosis to constrict the pupil. We love how pharmacology can be related with these amazing stories and lineups that allow us to remember the functions. Because when we get to the drugs, there's so many drugs that we can't remember the actions of. With these stories, we can enhance that. So what are the indications of cholinergic pharmacology? Urinary retention to increase urine output. Glaucoma, open angle or narrow angle. We don't need to get into the details. However, glaucoma is extremely important. We just talked about how it does that with the intraocular pressure reduction. Treatment and diagnosis of myasthenia gravis. Remember that acetylcholine helps improve smooth muscle actions or skeletal muscle actions. Well, myasthenia gravis is the drooping of eyes. Remember? Drooping of eye, where there is lack of muscle control. The treatment and diagnosis of which is led by cholinergic drugs because it cancels the drooping and gives us control. Tuberculin poisoning, not so important, but we'll talk about that later. And it will reverse the actions of atropine. Atropine is a new term introduced here. Atropine is anticholinergic drug. So what's the antidote of atropine? Acetylcholine. It is a cholinergic drug that works against an anticholinergic drug. So what are the contraindications? When should we not use cholinergic drugs? And bronchial asthma. Remember, it causes bronchoconstriction. Therefore, if you have bronchial asthma, we don't use cholinergic drugs. Peptic ulcers. Remember, it increases all secretions of all glands. Then it should also increase HCl in the stomach. Therefore, if you have peptic ulcer and GERD, we can't have cholinergic drugs because it will then increase HCl production. Hypotension history. Remember, it calms the heart down and leads the blood pressure low. So if you already have a hypotension emergency history, then we can't use cholinergic drugs. Irritable bowel syndrome, which includes diarrhea. So if GI motility has increased, then we cannot be using cholinergic drugs for irritable bowel syndrome, but only in severe cases. That makes this a relative contraindication, not an absolute contraindication. Similarly with urinary tract blockage. If your tract is blocked and acetylcholine's job is to increase urine output, then that blockage with this output will clash each other. Okay, what are the side effects of cholinergic pharmacology? We have diarrhea, too much GI. Flaccid paralysis. Now, what does flaccid paralysis mean? It's a new term introduced now. Flaccid means loose. Paralysis means lack of movement. When does this happen? This happens when a lot of muscle movement takes place. Muscles get tired and then they become loose. Once they're loose, they stop moving. That's flaccid paralysis. Tired muscles. Excessive lacrimation, way too much tears, way too much salivation, and way too much urine output. These are side effects of the drugs. Now let's talk about drugs themselves. We've understood the actions, right? We've understood what agonists are able to do in cholinergic systems. So let's just put names to it. A direct-acting cholinergic group set is known as pilocarpine, bethencoul, carbachol, where indirect-acting cholinergic drugs are reversible and irreversible in nature. Now, irreversible, the organophosphates, are extremely dangerous and they're not used in dentistry. So why are we learning about them? It's because we have to learn about the reversal mechanism of this dangerous drug, and that's a part of dentistry. Where reversible means over time their effects wear off and any other drug can come into its place and act opposite to it, such as physostigmine, neostigmine, pyridostigmine, rivastigmine, galantamine, idrophonium, ambinomium, tacrin, and donazepine. Now, these drugs are remembered best by stigmines. Indirect acting cholinergic agonist, stigmines. Okay? Direct acting, pilocarpine, bethencoul, carbachol. Now, how do we remember this? Very easy. The way I do it is direct acting cholinergic are chols. And pilocarpine is one of the most used drugs in cholinergic, so it's hard to forget these drugs. Indirect acting are all stigmines. Remember, indirect acting, stigmines, indirect. Okay? Just remember it this way. I know once we start studying them, it becomes easier to remember the names, but the first time we look at these, it just becomes overwhelming. So let's break these drugs down one by one. Direct acting, pilocarpine, direct acting. The use and indication is glaucoma and xerostomia. Why? Because the mechanism says that it decreases intraocular pressure, causes meiosis, and works to increase salivation. We looked at all of that in detail in the pharmacology section of it. Now in the drug section, moving on to the bethencoul, it's used for urinary retention. So if a question is asked, which drug is used to increase the urine output by bladder contraction stimulation? Bethencoul comes into play. How I remembered bethencoul was Beth kind of sounds like bath, and bath has to do with washroom. Just one way to remember urine retention. So it treats urine retention by stimulating bladder function, smooth muscle actions, increases GI motility as well. Carbachol is for glaucoma. Carbachol is for glaucoma because all direct-acting cholinergic drugs will one way or the other decrease intraocular pressures and it increases the drainage of all that fluid in the eyes. Moving on to the indirect-acting cholinergic drugs, there's physostigmine, which is a reversible indirect-acting drug. Again, these are all still agonists, guys. The uses are glaucoma, as we know now, urinary retention, and treatment of atropine overdose. How does it do it? Well, indirect acting will inhibit the acetylcholine esterase, by then it'll increase the acetylcholine activity at the neuromuscular junction. Neostigmine is a newer drug, hence neostigmine. It treats myasthenia gravis because it is long-acting. It treats it because it's long-acting. As it inhibits acetylcholine esterase, it increases the acetylcholine activity at neuromuscular junction. Neuromuscular junctions are at skeletal muscles. Skeletal muscle activity is in our control. It is voluntary, such as the ones used in myasthenia gravis. When myasthenia gravis happens, our eyes droop, right? We lose the control of voluntary muscles. When that happens, all we require is more ACH. Therefore, neostigmine will inhibit acetylcholinesterase, thereby increasing ACH activity and enhancing the voluntary control lost due to myasthenia gravis. Because this is long-acting, it treats it. Rivastigmine, galantamine, and donepezil with tacrin are all used for Alzheimer's. Now, why is Alzheimer's important right now? Is because we need to know that these drugs affect the CNS. It crosses the blood-brain barrier, inhibits acetylcholine in the brain, increases acetylcholine activity in the brain, right? It stops the enzyme that breaks down acetylcholine and increases the actual neurotransmitter activity in the brain, not in the neuromuscular junction. Moving on to idrophonium. Idrophonium is used in the diagnosis of myasthenia gravis. Same function, but it's short-acting. Therefore, it helps us diagnose myasthenia gravis, that once the inhibition of acetylcholinesterase takes place, there's an increase in acetylcholine activity at the neuromuscular junction for a short amount of time. That tells us that with this drug being administered, idrophonium, the patient started to have control over the voluntary muscles. And then in short term after that, the voluntary muscle control is lost. That lets us know that the person has myasthenia gravis. And last but not the least of the drugs for agonists, we have organophosphates or sarin gas. Now, just a little backup. Sarin gas was used in the war in Syria to kill people with respiratory failures and asphyxia, which is not being able to breathe, guys. This is a dangerous drug. It is actually a pesticide used to kill pests in agricultural activities. So, the mechanism is that it reactivates acetylcholinesterase, it decreases acetylcholine in the synapse, it reduces the muscle activity, causes skeletal muscle paralysis, and then leads to respiratory failure. But this drug is reversed by pralidoxim. This little box right here is the most important part of this entire slide, you guys. The reversal of organophosphate poisoning is by pralidoxim. Now we're moving on to anticholinergic. Now guys, this section of the lecture today should be extremely fast. We know why? Because it's completely antagonizing. It is completely opposite of what we just talked about. For example, just as a little recap, the agonist would have decreased heart activity. Then what do we think the antagonistic would do? It will increase the heart activity. We knew that the tears and saliva were increased with agonist. Then the antagonist will reduce them. Very simple. And that's how we will determine the actions and pharmacology of it. See, the anticholinergic pharmacology is also known as parasympathetic, and the word lytic means to break, right? Parasympathetic. They work in three groups: antimuscarinic, neuromuscular junctions, and ganglion blockers. So antimuscarinic, because all of these receptors in the cholinergic pharmacology are muscarinic. Therefore, they will be blocked. Antimuscarinic. They act to block the postsynaptic targets, such as muscarinic receptors, on various sites, such as smooth muscles, hearts and gland, and etc. While neuromuscular junction blockers will act to block the postsynaptic targets on nicotinic receptors located on skeletal muscles only. That's somatic nervous system. So remember, when we were talking about the somatic nervous system, we had acetylcholine being used to skeletal muscles. Their receptor was nicotinic receptor. Therefore, the neuromuscular junction will block nicotinic receptors at skeletal muscles, only at somatic nervous system. And then comes ganglion. Now this one is very large, vast in action, because it'll block all ganglionic nicotinic receptors in order to treat hypertension, because it can also affect sympathetic nervous system. Wow, what does all of that mean? Well, let's take a look here. Remember, sympathetic nervous system or parasympathetic, both ganglions are nicotinic receptors, right? And acetylcholine goes there, and affects. And afterwards, it can change into norepinephrine, or it can remain the same. We don't really care about that right now. What we care about is ganglionic receptors. When ganglionic receptors are blocked, not only is parasympathetic blocked, but also sympathetic is blocked. And when sympathetic nervous system is blocked, all adrenergic receptors are useless. And thereby, it can control hypertension. More about this is in lecture 2, guys. So please follow the video for more. Now, an example of what the balance is between cholinergic and anticholinergic, we need to know that pilocarpine, which was the direct-acting cholinergic drug, will cause meiosis. Remember? Contraction of the pupil, near vision. Well, atropine, which is one of the most common anticholinergic, will cause what is known as mydriasis, which is dilation of the pupil. It makes the pupil larger. To view, far vision. So we could see more light can enter. Unlike pilocarpine, which is small pupil. So we're going to go opposite in direction now. So target tissues. Obviously, these will remain the same for the antagonists. In cardiovascular system, we now know that antagonistic activity will increase the activity of the heart, causing tachycardia. In respiratory system, it will decrease the respiratory smooth muscle action, causing bronchodilation, decreasing mucus secretions. In gastrointestinal system, it will decrease the GI motility and peristalsis. It will delay the emptying. In other words, it will cause constipation. Excretion glands. It will decrease the urinary output, decrease the lacrimal secretion, decrease the salivation. In other words, it will cause dry mouth. Eyes and vision causes mydriasis, which is dilation of the pupil, because we want to see far away, more light will enter. Now, why are all of these being repeated again? Is because we need to understand an equation. For example, if cholinergic was going to decrease heart activity, cause bradycardia, then anticholinergic will increase heart activity and cause tachycardia, right? For example, when cholinergic increased smooth muscle movements at lungs, it caused bronchoconstriction. This one, anticholinergic, will decrease it and cause bronchodilation. So that's the balance between agonist and antagonists. Okay, guys? All right, let's talk about indications. When should we use anticholinergic? When there is motion sickness and we need to decrease the GI motility. When there is a reason to achieve a dry field in dentistry right before the treatment, right? We want less saliva. And then preoperative medication for general anesthesia and intubation. Remember, neuromuscular blockers, NMJ, neuromuscular junction blockers, what they do is they stop muscle movements. So when somebody's being intubated and it's resisting because of the throat muscles, this anticholinergic medication could allow us to do intubation much easily because it blocks the neuromuscular junction. Same thing with general anesthesia and eye exam, because it will increase the diameter of the pupil and let more light in, causing mydriasis. Therefore, eye exam. Gastric ulcer and diarrhea, it's used to treat these things because we need to decrease the GI motility. We need to decrease the HCl production. Then comes severe hypertension. Ganglion blockers are used. Ganglionic blockers will also stop the sympathetic nervous system, leading to the blockage of adrenergic receptors. When they are blocked, the heart is blocked, leading to a decrease in the heart because of ganglion blockers themselves. So if we go back here, it says it increases the activity of the heart. Yes, it actually does. Anticholinergic, they increase the activity of the heart. However, ganglionic blockers, they will stop it because it affects the sympathetic nervous system. So don't be confused when we see that there's a severe hypertension and anticholinergic drugs are used. Well, specifically ganglionic blockers are used. And bradycardia. For bradycardia, atropine is used because atropine is an anticholinergic drug that belongs here. Okay, perfect. Asthma and COPD, we know that asthma and COPD have two things in common. There is bronchoconstriction, and COPD will have increased mucus, right? When anticholinergic drugs are taken, there's bronchodilation and there's a decrease in secretion. That's why they could be used in asthma and COPD. When should we not be using anticholinergic? Well, in glaucoma, because it works opposite to cholinergic. This one will increase intraocular pressure, and that's very damaging, guys. Urinary tract obstruction, when we already have an obstruction and we further reduce the urine output. Nasal congestion, when you already have congestion and then we reduce the sinus secretions. Prostatic hypertrophy, the size of the prostate will increase, causing obstruction of the urinary tract, and further these drugs will reduce their urine output. And irritable bowel syndrome, again in severe conditions only, and cardiovascular disease such as tachycardia, because when bradycardia is treated using atropine, overdose of atropine will lead to tachycardia. So if you already have tachycardia, we shouldn't be using atropine. So what are the side effects? And this part should be extremely simple, guys. It can cause dry mouth, xerostomia. It can cause blurry vision because our pupils are all dilated. It can cause tachycardia, urine retention even more, constipation because of lack of GI movement, and again, flaccid paralysis because the skeletal muscles are also blocked. Remember, in such as intubation procedures. So let's put some names to the categories. Antimuscarinics are atropine, ipratropium, scopolamine, cyclopentolate, and tropicamate. These are antimuscarinics. We need to just remember one thing. All of these muscarinics are cholinergic receptors. Okay, cholinergic receptors. Muscarinics have M in them, and nicotinic, the other receptors, have N's in them. That's just one way of remembering. However, when we go through the charts, you'll remember all of these by heart. Then comes neuromuscular blockers, which only work at the somatic system. And how do they work physiologically, molecularly? We'll just discuss in a second. Succinylcholine, tuberculin, and all the curiums are used as neuromuscular blockers. Ganglion blockers are hexamethonium and mecamylamine. Again, ganglion, whenever you see all that, remember sympathetic nervous system, because the act on the heart gets confusing when we don't remember that. It's hexamethonium and mecamylamine. Okay, heart muscle, hexamethonium, mecamylamine. All the curiums are neuromuscular, right? Q, muscular. Just one way to remember, you guys. Okay? Now, succinylcholine, one of the most famous drugs in neuromuscular blockers, works this way in two phases. Remember the word flaccid paralysis. Okay? Let's discuss that. First of all, when succinylcholine comes into the receptors, the nicotinic receptors located at the neuromuscular junctions, it sits on it. And because it does, the membrane depolarizes, which means it gets activated, resulting in initial discharge of muscle movements. All of the fast muscle movements are known as transient fasciculation. So let's write that down. Fasciculation. Transient fasciculation. So very high movements, almost like tremors. When that's done, the membrane then repolarizes, gets tired, and stops working, and the receptor becomes desensitized to the effects of acetylcholine, and therefore the muscle movement stops and the muscles become paralytic, leading to flaccid paralysis. That's succinylcholine. How do you remember this? So how I do it is this. We know that succinylcholine causes flaccid paralysis. We also know that acetylcholine causes muscle movement, right? So if acetylcholine causes muscle movement and succinylcholine causes paralysis, then when you take succinylcholine, it would really suck to be choline. Therefore, no movement. Just another way to remember. It is the antagonistic of choline. It would really suck to be choline. Therefore, no movement. Just another story format to remember the drug names. So let's break each drug down one by one like we did for cholinergic. So we have atropine, which is used for preoperative dry fields. We now know why. For reduction of bronchial secretions in the lungs. It is an emergency medication for bradycardia and hypotension. So it's an emergency drug to allow an increase in the heart rate, increase in the blood pressure. It's a preoperative eye exam because it dilates the pupils and it treats GIT ulcers and diarrhea. Very important drug, right? As it inhibits the muscarinic receptors at the target tissues. Scopolamine is an anti-motion sickness and sedation drug. This specifically works on the GI tract. Okay? There's a scoop of ice cream. Ice cream is something we eat, and because of which we can fall sick. So scopolamine will stop that sickness. Just another way to remember it. I know it may sound silly and a little funny, but believe me, these are the ways you can remember the drug's name in a jiffy, because these exams have a lot of material to remember. Okay, guys? Hope you guys like the method, and apologies if it sounds silly. Inhibition of muscarinic receptors at target tissues, specifically at GI. Cyclopentolate. Cyclopentolate causes mydriasis. Remember, cycles are round in tires. Their wheels are round, and so is the eye, specifically the pupil. Cyclopentolate causes mydriasis, which is dilation of the pupil. Again, muscarinic receptors at the eyes. Ipratropium bromide. Ipratropium bromide is one of the most famous drugs for treating asthma and COPD because they work to cause bronchodilation and allow us to breathe better, and it will reduce the bronchial secretion and allow the COPD patients to breathe better. Moving on to neuromuscular blockers. Remember, it sucks to be choline, so no movement, and therefore it leads to paralysis. So skeletal muscle relaxation, way too much relaxation. and endotracheal intubation support. So this is a great example. When do we want skeletal muscles to be relaxed? During endotracheal intubation. That's when succinylcholine can be administered. All it does is it inhibits the nicotinic receptors at skeletal and striated muscles and acts only on the somatic systems at the neuromuscular junction blockers. Tuberculin is another example. What tuberculin or other curiums, what they do is support the other drugs during general anesthesia application because they also work to relax skeletal muscles. Remember, all it does is it redirects acetylcholine and sits on its postsynaptic receptor. It inhibits the nicotinic muscle receptors at the skeletal muscles, acting on the somatic system. And last but not the least, the dangerous guys, the ganglionic blockers. Remember, ganglions are going to affect sympathetic nervous system. So, heart muscles, hexamethonium and mecamylamine are used to treat severe, moderate to severe hypertension. How? Well, think of it this way. We'll see in the next lecture with the sympathetic nervous system that sympathetic nervous system, also known as adrenergic nervous system, has direct effect on heart, specifically beta 1 receptors. I know I'm jumping ahead, but it's important to grasp the ganglion blockers. When beta 1 receptors are activated through adrenergic drugs, then the heart activity goes up, the blood pressure, heart rate, the cardiac output, everything goes up skyrocketed. What activates this is adrenergic drugs. Adrenergic drugs are sympathetic nervous system drugs. What's the biggest example? Epinephrine. So when epinephrine is injected into our muscles, our hearts start racing, right? That's because beta 1 receptor, the adrenergic receptor, is activated, and therefore blood pressure, heart rate, cardiac output goes up, 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 up. When that happens, we need to block all of this. How do we block it? We will use hexamethonium and mecamylamine to stop all the ganglions. Remember, CNS, ganglion, target tissue. We need to stop everything here, all the systems. Just shut the cable off, turn the TV off. We need to shut the engine right there so that we can prevent the sympathetic nervous system from raising the heart. In other words, treating moderate to severe hypertension. The only time in our lives we go to the basement and turn off the main switch is when there is a severe flooding. Severe flooding. And that's where we go and turn the main switch off. Okay, just remember that, you guys. Perfect. So that was our first lecture today. The resources used are Lippincott for pharmacology and Litton-Fellows for dental management. And the links are in the description for the textbooks. Thank you for watching, you guys, and stay tuned for more pharmacological and other subjects in lectures so that we can clear our AFK, INBDE, BDS, specifically second year, you guys, DDS, and the biggest of them all board exams. These are bases. So please follow us, like, share, and subscribe, and see you in the next lecture.